Module 20, Iron Depletion in Athletes. What are the functions of iron? Well, the first function is to be a part of hemoglobin and myoglobin. These are proteins that are necessary for oxygen transport in blood, and myoglobin being the analog version of that in muscle tissue. So it is a constituent of erythrocytes or red blood cells. Iron's function is basically to bind iron to the hemoglobin protein. Iron is also necessary for enzymatic reactions involved in energy production. It's also a cofactor for enzymes and pathways. You can see that this slide at the bottom here shows you a number of enzymes that require iron to be present in order for that reaction to be catalyzed properly and take place. Are athletes more susceptible to iron deficiencies? Well, the literature seems to be mixed and inconclusive with data at this point. Some studies do say that iron is increased, while others say that iron is actually decreased. The prevalence in athletes as far as iron deficiency anemia seems to be about less than 3%, which is similar to untrained controls. So we definitely need more work in this area, particularly for our higher risk populations like adolescent girls, women, teenage boys, and young adult men. What biochemical measures are used to assess iron status? Let's take a look at these. So the first of which that's up on the slide here is serum iron. So this is looking at the concentration of iron in blood. Serum is just another way of saying that you've taken a blood sample, allowed that blood sample to clot, and now you're using that sample to measure iron status here. So we're just looking at the amount of iron that basically has been dissolved in blood freely. It is a measure of free iron and iron that's bound to transferrin and not bound to hemoglobin. That's important to consider here. It's usually less in females than males. So in females, we're looking at about 11 to 29 micromoles per liter, whereas in males, it's about 14 to 32 micromoles per liter. Athletes do tend to have lower concentrations of serum iron, and the nice thing is that it is not affected by the menstrual cycle, which gives a more consistent result. However, the big problem here with serum iron is that there is a pretty large diurnal variation. So in other words, day-to-day variation of iron, serum iron is huge. In the morning, it tends to be the highest. Late in the day, it tends to be the lowest. So depending upon the time of day that you choose to take a blood sample could determine what the level of serum iron will be. So thusly, it is a poor index of iron status and shouldn't be used as a way of diagnosing somebody with iron deficiency anemia, simply because there's huge day-to-day variability. Next up is serum ferritin. Now, serum is simply blood that's been allowed to clot at room temperature once you've drawn the blood sample from your patient or client. And the reason why you want to do this is because clotting proteins can sometimes interfere with assays for determining specific variables. So in this case, the clotting proteins would interfere with analyzing blood for ferritin. So ferritin is simply a protein that is found intracellularly that allows us to store iron bound to it. There's also another protein that does something very similar, and it's hemosiderin that does also store iron as well. We have ferritin stored in the liver, reticular endothelial system as well, the part of the immune system, the spleen, and the bone marrow here. Now, there's a small amount of ferritin that will actually leak out from cells and leak into the blood. And so this amount that's leaking out into the blood is the amount that we're actually measuring. And something to keep in mind here are these 2 points, which can be a little confusing, so go ahead and take a look at these a little bit more closely. But the amount of ferritin that leaks out into blood is directly proportional to the amount of intracellular ferritin. So as ferritin stores go up, so does the amount that's going to be found in blood. Now, if we're talking about the amount of iron bound to ferritin within the cell, the amount that's in blood is indirectly proportional to the amount of iron bound to ferritin. So as the amount of iron that is decreased intracellularly, then the amount that's found in blood will actually be a little bit higher. So it's opposite of what you would expect here. So this is actually a good indicator of iron stores. So it tells us a little bit about what's going on as far as mobilizing iron in and out of the cells. In athletes, it's been found that women athletes, the levels should be around 35 micrograms per liter. In men, about 69.2 micrograms per liter. Now, in adolescence, there's some interesting things that happen that we want to make note of, and that is that adolescents may actually have low serum levels of ferritin with a high dietary intake and supplement of iron, and there seems to be a slow rise in ferritin levels, with the majority occurring during late adolescence and early adulthood. Now, females actually don't show this trend. They actually slowly increase ferritin levels until menopause, and then once the postmenopausal years hit, there's a sudden rise in ferritin levels. With elite athletes that have been training, you may actually see a 25% decrease in serum ferritin, and this may be exaggerated with weight-bearing sports. The total iron binding capacity, or TIBC, ranges from about 270 to 400 milligrams per deciliter, and there are various measures that we can look at. The first of which is transferrin. This is a protein that essentially binds iron so that it can transport iron in the bloodstream. So this is how we move iron around in the human body. Intracellular amount of iron is actually going to regulate the synthesis and secretion of transferrin. So if we decrease intracellular iron, we actually will increase the amount of transferrin. So this should make sense, because if the cells are actually low in iron, then we want to transfer more to the cells that need it. And so we're trying to increase the expression, upregulating transferrin, and moving that iron to where it needs to go. Now we can also look at another measure here, and that is transferrin saturation. So how much iron is actually bound to transferrin, how much it's saturated with iron. So that's another measure we can take a look at. We can also look at the serum iron to iron binding capacity ratio. So the amount of iron that's available in the serum, and as well as the binding capacity that's available for iron to potentially load onto transferrin. So this is usually around 20 to 40%. If it's less than 16%, you're going to get red blood cell production is going to be most likely affected. And if it's greater than 15%, we actually might suspect an iron overload, as in the case of hemochromatosis, as we'll talk a little bit about that later on. So during the early stages of depletion of iron stores, you will see an increase in transferrin, and that will be at the higher end of the usual range, or even slightly higher than that. So again, think about what's going on here. We're depleting intracellular levels of iron, we're removing it, so transferrin is moving iron around to where it needs to go and where it's needed. So those levels are going to be higher. So during iron deficiency, when we get to that stage, then transferrin saturation actually is going to decrease. So one of the notes that's important here to remember is that it's not a sensitive measure for low iron levels and pre-anemic conditions. So it's kind of in the middle as far as when you'd want to look at total iron binding capacity. We can also measure the transferrin receptor, and these are proteins that are expressed on the phospholipid bilayer. So when a cell needs iron, it's actually going to express more transferrin receptor, which means that that is going to allow more transferrin to bind to the receptors, and that will control the entry of this iron-bearing transferrin into the cell. So when a cell needs more of something, it expresses more receptors. So in this case, when the cell needs more iron, it will express more transferrin receptor, so that then transferrin knows to bind to the receptors, and you can deliver the iron to that particular cell. It is a positive sensitive measure, that is looking at the transferrin receptor. It's quantitative, so we can actually add up all of the amount of receptors that are being expressed. It is an early evaluation of iron deficiency in tissues. Again, think about what's going on here. If I need iron, I'm going to express more transferrin receptors. So that's going to tell us a little bit about what's going on. It means that we're not having large stores of ferritin in the cell. So we're going to express this transferrin receptor to get that iron into the cell. So if serum ferritin is less than 12 micrograms per liter, that receptor, transferrin receptor, is going to increase by about 3 to 4 times. So that's indicative of iron deficiency anemia. Now the good news is that it's not sensitive to plasma volume changes, which is important for athletes because with training you are going to see quite a bit of a shift in plasma volume. So it's a nice stable measure for athletes. It is, however, unreliable for detecting anemia, as well as red blood cell hyperdestruction or hypoproliferation or disorders of erythropoiesis. So we can use it as an early indicator of iron deficiency anemia and not when we have other issues going on with red blood cells. So we do need a little bit more research to kind of tease these factors out before we start recommending the use of transferrin receptor for the masses here in the athletic population. Then we have hemoglobin and hematocrit, also known as H&H. Hemoglobin, of course, is the protein that is rich in iron and binds oxygen so that we can deliver oxygen to tissues to perform oxidative metabolism. So it's a part of the red blood cells. About 90 to 90% of total iron is bound to hemoglobin. So that's a huge location for iron to be found. 10% of the iron is actually going to be bound to myoglobin. So remember that myoglobin is the analog to hemoglobin just within muscle. We also have hematocrit, which looks at the concentration of red blood cells. These values are usually going to be higher in athletes, usually higher in men than in women, and they are positively associated with BMI in athletes, so BMI being the body mass index. It's only going to decrease with severe iron depletion, so you really have to use up iron in the iron stores, so using up a lot of the ferritin and mobilizing that ferritin in order to see some significant changes with hemoglobin and hematocrit. There is a small diurnal variation of about 3 to 5%. And the nice thing with H&H is that we can also look at red cell morphology, and that is morphology is basically the study of shape and looking at red blood cell shape. So during iron depletion, what ends up happening is that you get microcytic red blood cells. That is, the cell size actually progressively gets smaller. We can also look at the reticulocytes, and these are basically red blood cells that are released recently from bone marrow, so they're fresh, brand new red blood cells or precursors to red blood cells that are going to mature into red blood cells. So we can actually use that also to predict iron deficiency, which is kind of interesting. Then there's the full red blood cell count, which looks at changes in red blood cells in individuals developing iron deficiency. So we look at the reticulocyte hemoglobin content, which is going to be reduced in someone who has iron deficiency. We can look at the percent hypochromic, which chromic is just looking at the pigment of the red blood cells. And so in iron deficiency anemia, what ends up happening is you have a lot less pigment, so the red blood cells will look pale. And we also look at the percent microcytic cells, so the amount of cells that are smaller than they're supposed to be. So red blood cells can become quite small as well as pale. Now, we can also look at the hemoglobin content of red blood cells, and we know that will be reduced with iron deficiency, and that's what we call the MCH, or the mean cell hemoglobin concentration. We can also look at the red blood cell mean cell volume, or MCH, which is mean cell volume. That will be reduced. So this is basically looking at the size of the red blood cell. We can also look at the red blood cell hemoglobin concentration, which tells us a little bit about the pigment. So it will be reduced, which means that it'll be hypochromic. So we call that the MCHC, which is the mean cell hemoglobin concentration. So in iron deficiency anemia, we get microcytic hyperchromic red blood cells that can appear as the severity of iron depletion progresses. Then there's the zinc to protoporphyrin to heme ratio, or the ZPPH. This is kind of a neat one, although it is kind of expensive to perform, so you won't see it done in a clinical setting very often. But protoporphyrin 9 is actually a protein that binds with iron to form the heme protein of hemoglobin. The neat thing is that it also binds to zinc. So 1 out of 20,000 hemoglobin molecules with sufficient iron will actually bind some zinc. During deficiency, so when someone has iron deficiency anemia, then what we see is that 1 out of 12,000 molecules of hemoglobin actually bind with zinc. So there's more zinc being bound to the protoporphyrin 9 protein. Restated, you can see a concentration of the amount of zinc to protoporphyrin protein being greater than 80 micromoles per mole. So this is kind of a neat indicator early on for iron deficiency. So that's kind of a nice indicator. Now we can also look at free erythrocyte protoporphyrin, or the FEP, which measures the derived product of zinc binding to the protoporphyrin protein. So we can also look at that. That's normally less than about 40 micromoles per liter of red blood cells. It does increase just before the onset of anemia. So again, a nice early indicator. So they're both more sensitive as an early detection of depletion than hemoglobin. However, it is costly to perform. This is independent of hematocrit. It's not affected by hydration, which is good because athletes do, again, fluctuate as far as their hydration status goes and their plasma volume. It's not going to be altered by a recent blood loss, and it's not related to other causes of anemia and iron deficiency. The reference values that are used to detect the stage of iron deficiency or depletion or anemia are going to be the ones that we use for the general population, and this could potentially lead to an erroneous conclusion in athletes. So that's something that we do want to be aware of, that we're not quite 100% certain as far as refining our reference values and determining the cutoffs for saying that an athlete would have iron deficiency anemia. So we need to combine these measures of iron depletion and status of iron and not just rely on one single measure. That's really important. So in a hospital setting, we'd always be using a combination of these 2 or 3 in order to confirm a diagnosis. So we need a combination of storage iron as well as a transport iron measure and red blood cells in order to correctly diagnose iron deficiency anemia. So low blood levels are often normal for certain individuals, which is something that we want to be careful of, especially in adolescence, as we discussed. There actually may be more iron or absorption that compensates for this low level in the blood. And there are factors that are closely associated with maturational age. So as a teenager develops into an adult, things that are going to affect these blood measures are going to include body mass, gender, genetic factors, as well as the amount of physical activity. One of the things to keep in mind is that there can be some variability in these measures of iron status because of any cell-mediated responses to stress. So negative acute phase respondents tend to decrease these blood measures, as well as positive acute phase respondents tend to increase these measures of iron status. So that's something that you want to keep in mind as you're evaluating these athletes for iron status. How is iron balance maintained? The human body is excellent at reusing and recovering iron. Iron is arguably the most problematic nutrient for us as far as getting it from our diet across the lifespan. So 90% of iron is actually recovered and reused, which is good news for us. About 10% is going to be lost. So 10% will be excreted, and this is the 10% that we're trying to replace with dietary consumption. As we discussed earlier, the prevalence of iron depletion is about less than 3%. In athletes, the prevalence tends to be very similar to untrained adults. What factors contribute to iron depletion? In athletes, it may be a result of hard training or recent increases in intensity of training. This is going to increase the iron requirements as well as increase iron turnover, which then can quickly deplete iron stores. In females and athletes in general, they're going to be at greatest risk for iron depletion because they may have difficulties in meeting the actual requirements through the variety of combination of foods that they are ingesting. Perhaps there are some absorptive issues that may come up. The high carbohydrate intake may actually be high in compounds that will inhibit iron absorption, like phytates. There may be some physiological mechanisms that will reduce the amount of iron available to them, as well as any medical factors. What are the stages of iron depletion? Well, the first is, of course, just normal iron storage. And then the next step would be the depletion of iron stores, where total iron binding capacity reaches greater than 400 micrograms per deciliter, and then serum ferritin levels drop below 12 micrograms per deciliter in individuals who are older than 15 years of age. The cutoff range here is somewhere between about 16 to 30 micrograms per deciliter. The next stage is early functional iron deficiency. So this is where hemoglobin is actually normal, so it's not going to affect performance, but iron levels are deficient. Transferrin saturation drops below 16% in individuals greater than 10 years of age. And then the serum transferrin receptor is going to be upregulated, so we're going to see that as 8.5 milligrams per liter. Then the next stage, the final stage, is where we have iron deficiency anemia. And this is where hemoglobin is going to be affected. So in males, that represents less than 130 grams per liter in individuals who are 15 years of age or older. In females, that's less than 120 grams per liter for individuals greater than 15 years of age. And then the mean cell volume, this is the size of the red blood cells, is less than 80 FLs. What is microcytic hyperchromic anemia? This is what we refer to as iron deficiency anemia. So red blood cells are going to be small and pale. So we use our measures that we discussed earlier to determine the iron status. So below population standards and below usual or normal levels will cause inadequate iron availability in bone marrow. So hemoglobin and red blood cells will be limited. The red blood cells will be small, so they're microcytic, and they are pale, hypochromic, and brain and muscle metabolism, immunity, and temperature control are all going to be affected as a result of having iron deficiency anemia. The good news is that anemics do respond well to dietary intervention as well as iron supplements. How does microcytic hyperchromic anemia affect performance? Well, if we think about the significance of oxygen to oxidative metabolism and the production of ATP, I think that really highlights the need that particularly endurance type of athletes need for hemoglobin reliance and iron, and the importance of iron binding that oxygen. So performance is going to suffer nonetheless. So they have a decreased aerobic and endurance capacity, so their overall work capacity is going to be reduced, as well as their energy efficiency. The athlete's going to feel very lethargic and not very energetic whatsoever. What is sports anemia? This is also called dilutional pseudoanemia. So it's not really a real anemia, because the profile of iron status measures are actually very similar to deficiency, but the red blood cells are going to be absolutely normal in color and size. So they're not going to be hyperchromic, they're not going to be microcytic. So low iron is not necessarily indicative of iron depletion or deficiency in athletes. What really could be the problem is the fact that particularly endurance type of athletes can expand plasma volume quite significantly, which if you add more water to blood, that's going to act as a diluent and make the concentration of hemoglobin and hematocrit look a lot less. So in an athlete, plasma volume actually can expand as much as 20%, particularly in runners. So that's huge. That can dilute the iron measures that we're looking at and isn't going to be necessarily indicative of iron depletion or iron deficiency anemia. This typically occurs early on in training. It's more prevalent during rest, injury, or the endurance phase of training, and it's highly unlikely to affect performance. So that's the reason why that the term sports anemia is actually discouraged in the sports world. It's not a genuine iron deficiency state, and it does not limit the production of red blood cells. However, low iron status should be used as a risk factor. What are the clinical symptoms of microcytic hyperchromic anemia? Well, athletes might experience fatigue, weakness, breathlessness, and impaired aerobic capacity. The skin might be pale, might get a slightly elevated pulse rate. They may feel run down or washed out. There may be some mood changes, diminished appetite. And these symptoms may manifest during mild anemia or even the depletion stage. These symptoms are sometimes confused with overtraining syndrome, glandular fevers, an infection, and sometimes even considered normal in the teenage athlete. On the other hand, elite athletes may actually be overly concerned. And sometimes the fatigue and lethargy of really hard training and exhaustive training may be perceived as iron depletion. What is the etiology behind iron deficiency anemia? There are several different mechanisms here, the first of which is physiological. We have an increase in vascularity, so we expand the number of blood vessels that we have, which means that we need an increase in red cell mass. So that we can carry more hemoglobin on those red blood cells and deliver more oxygen to the tissues that demand oxygen. This is dependent upon dietary iron, so the amount of iron that we're getting from diet is very important when we have this expanse in vascularity because of hard training. In adolescence, the requirements seem to be higher during the growth spurts. However, there may be some compensation from absorptive mechanisms that actually will deliver more iron to the areas that need it. Exercise and iron loss, there's no doubt that we do lose some iron this way. Some of the mechanisms include some sweat loss of iron. We also have gastrointestinal tract bleeding that can happen, and this is happening because of several different mechanisms possibly. The athlete may be on anti-inflammatories, that could cause some GI bleeding, desquamation of the intestinal wall lining cells, that simply means that the intestinal wall cells are sloughing off and shedding. We may get ischemia of the stomach, so there may be a lack of blood flow going to the stomach. Perhaps the athlete had some food in their stomach and they are now diverting blood away from the stomach because they're exercising, so there's competition for blood flow between the working muscle and the gastrointestinal tract. We can get hemolysis of red blood cells or the breakdown of red blood cells. That can be purely mechanical, just those red blood cells rushing through all of those blood vessels at a much higher velocity can cause trauma to those red blood cells. Capillary trauma is a very real thing, and that certainly can cause red blood cells to break apart and have hemolysis. Trauma to the bladder wall can also cause some bleeding. Weakening of membranes during running. This is kind of an interesting one. It's called foot strike hemolysis. This is where, because of all of the hard pounding on the pavement that each foot plant takes and transfers all of that energy throughout the body, that can actually cause some gastrointestinal tract bleeding. There can also be, of course, an injury that may happen with an associated blood loss that can cause some gastrointestinal tract bleeding. We also have menstruation that is sometimes targeted, but however, it doesn't seem that it's a major contributor to losses of iron, at least for most individuals. This, of course, should be taken on a case-by-case basis. With exercise, when we increase exercise and adapt to the exercise, eventually we get a reduction in the severity and the frequency of iron losses. But the one thing to keep in mind here is that there's no solid theory here, no one theory that's going to explain all of the increase in iron that an athlete may need. There are also dietary factors. We know that a low intake of iron-rich foods and or foods with low iron bioavailability, that is, there may be a large quantity of iron in that particular food item, but the availability of that iron for absorption may actually be quite low. So when you combine that with physiological mechanisms, that can then, of course, lead to iron depletion. And we know that low energy diets that are less than 2,000 kilocalories per day of energy can contribute to this whole process. We know that these individuals can end up with a low iron intake and a low iron status. Vegetarian diets are often the target here as well, because the vegetarian diet, of course, has fewer red meat products included in the diet, or even total exclusion if they're vegan. What's interesting is that vegetarians can have a lower iron status, but they'll have a similar intake with carnivores. So this really points to the fact that iron that's derived from plants is actually poorly absorbed compared with iron that we're getting from meat products. The lacto-ovo-vegetarians present a problem as well as far as iron intake. They may actually have a very high dairy intake, which is poor in iron, and calcium, we know, can actually inhibit the amount of iron that's absorbed. Then we have the natural foods eater that avoids commercially prepared foods, things like bread and breakfast cereals and other cereal-based products. These products have been fortified and enriched with iron. And in some cases, they have much higher amounts of iron than meat products. And so what happens here, of course, then that just reduces the overall intake of iron that the person has an opportunity to absorb. So as we've discussed in athletes, they may be on a very high carbohydrate diet, and then when you couple that with high energy expenditure, that actually could spell low iron stores. And in some research that was performed, this was found to be the case. So in this particular study, they found satisfactory levels of iron. However, they did have low iron stores, and they associated this to the low bioavailability of iron from some carbohydrate-rich foods. Now, when you couple that with the high energy expenditure here, that goes back to our physiological mechanisms that we discussed, and you couple that with the high carbohydrate intake, and then that sets up these athletes for low iron stores. Then there are fad diets and weight control products. These are often deficient in other nutrients. For example, the Just Fruit diet can be deficient in protein, iron, zinc, and other energy requirements for the athlete. So this can contribute to erratic eating problems, or as we discussed earlier, disordered eating, which then of course would reduce the overall iron intake for the athlete. What is the bioavailability of iron? What does this mean? Well, this is the amount that's ingested which is absorbed and utilized for metabolic functions. So this is related to iron status, the amount of total iron consumed, and other substances that it can actually inhibit or enhance iron uptake. So we want to look at iron status and the bioavailability. How much iron in the food that we consume is actually available for absorption. So we know that absorption in iron-replete individuals is anywhere from 5 to 15% from total diet. So about 5 to 15% of the iron that's present in food will actually be absorbed and internalized. We know that athletes can have an enhanced absorption of iron. We're not quite sure what the mechanism is there, but it perhaps stems from the fact that the need is greater and we're trying to replace that iron. What is the bioavailability of iron from foods? Well, we have several different sources, heme and non-heme sources. The heme source seems to give us a little bit more absorption. We get about 25% absorption versus non-heme iron sources, which give us 17% absorption. So perhaps there's some sort of intestinal mucosal regulation between non-heme and heme iron. We're not really quite sure. So non-heme sources include things like cereals, legumes, vegetables, and eggs, whereas the heme sources, we're talking about meat products. So meat, liver, seafood, and poultry, they actually contain both heme and non-heme, so about 30 to 70% is actually existing as heme iron. So it's a little bit easier to get iron from meat sources. Athletes who are consuming a high carbohydrate diet may be eating foods that are actually low in heme, and their diets may have a low bioavailability. So this is a concern for the athletes. What food components affect iron absorption? Well, we know that there are single plant foods that contain non-heme iron, and these have the lowest absorption rates, anywhere from 2 to 8%. So not a lot of that iron is bioavailable. We know that the diet does contain iron inhibitors. There are things like phytates, myoinositol hexaphosphate here, which is found in things like cereal grains, wheat bran, legumes, nuts, peanut butter, seeds, bran, soy products, soy protein, and spinach. That can actually inhibit the absorption of iron, so we'll absorb less iron if these phytates are present in the diet. We also have polyphenolic compounds like tannins and oxalic acid, which can be found in strong tea, coffee, herbs, teas, cocoa, red wine, some spices like oregano. If these compounds are present, of course, will inhibit some of that iron from being absorbed. We know that calcium in the diet also is going to affect heme and non-heme iron bioavailability, so consuming things like milk and cheese can actually prevent some of the iron from being absorbed. There are peptides from partially digested plant proteins like soy protein isolates and soy products that can actually inhibit iron as well. We know that minerals, overconsumption of zinc, calcium, and manganese also can affect iron. We can also throw copper in here as well. We know that there are some enhancers of iron absorption. The big one here is going to be vitamin C or ascorbic acid. And other low pH foods as well. But vitamin C is definitely the most potent enhancer of iron absorption. The low pH foods, what ends up happening is that the +3 will actually get converted into the +2 form of iron, which I'll talk a little bit more about here in a second. But we'll lose this +3 iron if we increase the pH. So by having a lower pH food, we actually can enhance the absorption of iron. So what are some low pH foods? Well, fermented foods, things like sauerkraut, miso, and some types of soy sauce. So what happens here is that vitamin C and low pH foods will actually act as a chelator of iron +3, which is the ferric iron. So we oxidize that iron. Basically, we are giving it an electron, and so we'll reduce iron to a more soluble ferrous form. So we reduce it to ferrous iron, so the Fe+2, which then increases the bioavailability for absorption. So we want to have our iron in the +2 form, which is going to give us the increased capability of actually absorbing that iron. So here's an example. If we took 110 milligrams of vitamin C, ate that with our hamburger, that's actually going to increase absorption by approximately 85% because it's in this +2 form of iron. So the recommendation here is that we have about 50 milligrams of ascorbic acid or vitamin C with each meal. And we know that if we consume a diet that's higher in phytates, which if we're increasing our carbohydrates, we probably will, and also the tannates, then we're going to need to boost that up to about 500 milligrams of vitamin C to offset some of the changes that would occur and inhibition of iron because of consuming these substances. We know that peptides from partially digested muscle tissue, so meat products here, are actually going to enhance iron absorption. This is often called a meat enhancement factor, or MHC. It enhances both heme and non-heme iron sources as far as absorption is concerned. So things like beef, lamb, chicken, fish, pork, liver all have these proteins that basically, once they get partially digested, they will help enhance the absorption of iron. Alcohol can also enhance some iron absorption, moderation of course, and some organic acids. So very low pH foods containing citric acid, tartaric acid, etc., things like citrus fruit can enhance the absorption of iron. There is some work with vitamin A and beta carotene that perhaps that may also contribute to the enhancement of iron absorption as well. What non-dietary factors affect iron absorption? Well, here are some iron enhancers as far as absorption is concerned. So we know that if we have a high gastric acid production, so that's going to decrease the pH, that's going to facilitate the conversion of +3 to +2 iron, which will increase the absorption. So we also know that if we have an increased demand for iron in the human body, situations like pregnancy and low iron stores, high altitude, if we've had blood loss, high exercise training, all of these things will actually enhance the absorption physiologically of iron. Some good iron inhibitors here that are not dietarily related. A good iron status. If our iron stores are great, then we're not going to absorb as much iron. If we abuse antacids, then we can actually get an increase in gastric pH, which then means that we're going to inhibit the iron absorption. What are the iron recommendations? Well, I'll refer you to the DRI tables for the general population. So adult needs, women about 18 milligrams per day, men 8 milligrams per day. So it's not much, but it can be a challenge to get in the diet here. Of course, we want to be more specific when we're working with athletes and not just using the DRI references for the mass population. Of course, the literature is more scant in this regard, so we always want to keep up to date on the current literature and see what's new and what's out there. As far as runners are concerned, we know that losses can be anywhere from 1.5 to 1.7 milligrams per day, and men 2.2 to 2.3 milligrams per day. So we'd want to basically take our DRI value then, and if we're dealing with runners, at least this study suggests that we increase the overall amount of iron in the diet by a few milligrams here. As far as losses in untrained adults, you can see that those losses are far less. In distance runners, there are needs in eumenorrheic women, so these are normally menstruating women, about 23 milligrams per day in distance runners. So that's significantly higher than just the adult means of 18 milligrams per day. In men, that value is 17.5 milligrams per day. So that is definitely significantly more compared with the DRI tables as well. This, of course, assumes that there's about 10% absorption from the diet. Again, we need more research in this area with athletes to figure this out and fine-tune the iron intake for specific athletic populations. So we do recommend that you follow the adult recommendations from the DRI tables, but then also include testing to verify that, in fact, the athlete's getting sufficient iron intakes. As far as female endurance athletes, we want to be careful here as well and provide a little bit more iron in the diet. As we saw earlier, the eumenorrheic women in this particular study needed 23 milligrams per day. So we want to make sure that if we're working with these types of athletes, that they're getting their appropriate amounts of iron in the diet. Of course, we want to emphasize diets that are high in total iron with good bioavailability. When is iron supplementation in athletes indicated? Well, if the athlete has depleted iron levels or has exhausted stores without the presence of anemia, then that may be a time to start considering an iron supplement. However, we should be aware that the iron supplementation in the diet has been linked to higher than usual levels of lactic acid, which could lead to sooner fatigue than the athlete is accustomed to. However, some have actually shown a decreased association, so it depends on the study that you take a look at. So individual practicing a plan here and figuring out what's working for the athlete is really the best plan of action. In a lot of studies, there haven't been any improvement in VO2 max whatsoever, so you shouldn't expect to see a large change in this. We know that depleted or exhausted iron stores are not necessarily going to limit performance when, and that's the key word there, when hemoglobin is normal. What type of medical intervention is necessary? Well, if you have an athlete that is anemic, they have microcytic hypochromic anemia, then of course iron supplementation is important. So this will actually, in some instances, increase performance quite a bit, because if they're deficient, then that's going to bring them back up as far as their hemoglobin content if that's been affected. In non-anemic, iron-depleted and iron-deficient team sports may actually not benefit at all from any kind of iron supplementation. As far as treatment goes, it really should be an individual analysis. That's the most appropriate course of action here. So we want to focus on an iron-rich diet and then have doses of iron supplementation greater than about 100 milligrams of elemental iron per day. In some severe cases, that may jump up to 300 milligrams per day, and they should take it on an empty stomach. Now, what's interesting about iron supplementation is more than likely they would need to have some sort of intravenous injection in order to bring their iron levels back up quite quickly. So you can see that recovery when you do that sort of thing can be about 3 months. If you're just relying on dietary supplementation, that would actually take 2 to 3 years to bring those storage levels back up to just 80% of where they were before. So supplementation is important, but also medical intervention as far as an intravenous injection is concerned is going to get that athlete back on track much sooner than if you just relied on the diet. Are there side effects with high doses of iron? Well, we're talking about 75 milligrams per day or greater as far as the iron intake, and we know that there's an increased risk of iron overload in individuals who have hereditary hemochromatosis. So this is a genetic condition where the amount of iron that's absorbed goes unchecked as a result of a lack of hepcidin, which is produced by the liver. It's a hormone that tells the gastrointestinal tract cells to not absorb iron when iron stores are full. So the reason why we're concerned about this is because iron storage can accumulate. So we know that iron can be stored in organs. We saw the protein earlier, hemosiderin, as well as ferritin. Hemosiderin happens to be the protein that is used when there's a large amount of iron present. So we tend to use it when there's an abundance of iron availability. So this can lead to hemosiderosis, which of course is the excess in iron absorption. So we get an excess iron absorption and accumulation in organs like the liver and the pancreas and the heart, which then leads to organ damage and possible organ failure. The prevalence in this hereditary hemochromatosis is about 1 out of 200 to 300 people. As far as plasma ferritin levels that may put somebody at risk for this, greater than 200 milligrams per liter in males aged 20 to 44 years of age, and greater than 150 micrograms per liter in females aged 20 to 44 years of age. Plasma levels of iron, if they're higher than 175 micrograms per liter, again, you may run into an instance of iron overload, and transferrin saturation greater than 60% would also be indicative of an iron overload. We know that iron can act as a catalyst to increase free radical generation. We know that iron has interactions with prescription medications, can lead to diarrhea or even constipation, can lead to abdominal discomfort, nausea. It can increase the risk of infection. And as we saw in previous sections, we can interfere with the absorption of zinc and copper. So intramuscular iron injections can actually lead to anaphylactic shock and even death. So there are some risks to iron supplementation as well as intramuscular iron injections. What are some good sources of iron? Well, the daily value is about 18 milligrams per day. The RDA value is 8 milligrams in males and postmenopausal females. And the RDA value is 18 milligrams per day for females. So it's kind of interesting to use that as a reference and then take a look at some dietary sources here. So I would do that, take a look at this list, and you may find this list useful if you are working with athletes who are concerned about their iron intake.